Welcome to Medical Myths, Legends, and Fairy Tales. I'm your host, Dr. Alan Christensen. Look, you know that between the latest online fads and the crazy media headlines, it's easier than ever to get confused about your health. And you and I just want to feel better and live longer. We want to know what works. And we can't wait for further studies. We need to make decisions today based on the best evidence we've got. Well, that's exactly what this show is here for. So let's get to it.
Hi there, this is Dr. Linda Kashaba from Integrative Health. Would you like some help with your thyroid? We would absolutely love to help you out. And guess what? We can even do remote care. Please call us today at 480-657-0003 to set up your first appointment. If you mention code podcast20, you will get 20% off from your first visit. That phone number again is 480-657-0003, and the code is podcast20. Can't wait to meet you.
Hey, Dr. C here with you. You've heard the whole thing about, if a tree falls in the woods and nobody hears it, was there really any sound? So if someone has a wonderful recovery from an illness and it's never reported or documented or tested in some way, did it even happen? All too often, I think practitioners can see benefits in their clients and maybe even multiple times and then make assumptions that their intervention had some effect. But there's so many ways in which, we can misperceive that. People can have conditions that they get better anyway, or maybe they're given a bunch of different therapies. One of them helped, some of them had no effect. We couldn't assume which one did that. Or maybe it was something that was subjective that got only a little bit better during the time in which they were on treatment, but didn't really improve in a meaningful way afterward. So anecdotes are things that the term anecdote, scientists really use in a derogatory way. They mean it's information that's not meaningful. I'm really excited about today's guest because she took her work and made it into more than an anecdote, and now it's having effects upon policy across the board. Dr. Terry Wahls, she's a clinical professor at the University of Iowa, where she conducts clinical trials testing therapeutic lifestyle and diet on multiple sclerosis, the progression of disease and the symptoms. She's the author of the Wahls Protocol and the cookbook, the Wahls Protocol, Cooking for Life. You can catch her on her TED Talk, and she does some great live events as well. We'll get some links for her resources. But yeah, dear friend, someone I greatly admire, and please enjoy this discussion I had with Dr. Terry Wahls. Hey, Dr. C, back here with you for another episode of Medical Myths, Legends, and Fairy Tales. Super happy to be joined by my friend, Dr. Terry Wahls. Terry, how you doing?
Oh, wonderful. I'm so glad to be here.
Always good to get a chance to hang out. So I wanted you to come on and talk to us because, you're really just an exemplar of someone who's gone beyond observation and anecdote and worked hard to create real evidence. And I think that there's a misconception people have that if they have an observation that they've had, or maybe a clinician has seen something happen multiple times in their practice, that's good enough to act on, good enough to interpret something, but also good enough to convince others and really create a new idea. But you immediately saw that was not the case. You had a powerful personal experience, but you realized that in order for that to be validated and then to affect policy, it had to go outside that and create data around that. Can you just tell us a bit about how this played out for you? Or
absolutely. So I'm really blessed in that the chair of medicine at that time, who watched me become severely disabled and then recovered, was a rheumatologist. And he told me to get a case report written up. And I'm like, on myself, goes, yeah. So I did that. And then we started keeping data up for a case series. We got that going. And then he called me back and said, Terry, what you really need to have you do now is to do some pilot studies and show whether other people can implement your complicated protocol or not. And I'm like, well, I've not really been trained in doing clinical trials. So he helped me identify some mentors and helped me launch my initial pilot studies, which have been then, of course, launched, really shifted the direction of my career. And so that's now what I do, are clinical trials looking at diet and lifestyle.
So that's incredible. So you're able to pull together the data step by step. And I understand now your work has been very influential in many, many different domains because of that.
Yeah, when I first started writing these grants and doing my protocols, the reviewers were just scathing that, clearly I don't understand the pathophysiology of MS.
Wow.
And so, they're very harsh. But, we kept at it. And then because private philanthropists had funded our early work, and we now were accumulating remarkably positive pilot data from these pilot grants that we're writing in these continued grants. And so then we started getting funding. But it was the early philanthropists that allowed me to do these small pilot studies that showed this remarkably successful approach.
And those that might not have heard, can you give us a bit about your story too, about how your health was affected and how the things you stumbled across really changed that?
Oh yeah. So so I'm an academic internal medicine doc here at the University of Iowa, and now just as I moved here, I was diagnosed with multiple sclerosis, and I wanted to treat my disease aggressively. So I did some research, sought out the best MS center in the Midwest. That was the Cleveland Clinic. Saw their best people, took the newest drugs, and these were drugs costing thousands of dollars each month.
Wow.
Relentless decline. Within 3 years, I needed a tilt recline wheelchair, and I was too weak to sit up in a regular chair. Now, fortunately, I'd been reading, the basic science, ancestral health principles, and functional medicine. I had adopted a paleo diet. I continued to get worse. I added some supplements. I continued to get worse. Then in the summer of 2007, I discovered the Institute for Functional Medicine. I had a longer list of supplements and a few more ideas. And then I, integrated what I'd learned from the ancestral health folks, the basic science, functional medicine. And then I had this really big idea, like, instead of relying on supplements, I should redesign my paleo diet in a very specific way to maximize the nutrients that I was taking in the supplement form. And so I did that. And, the speed of change was really remarkable. Within the next 3 months, my pain was gone, my fatigue was gone, my brain fog was gone, and I was steadily getting stronger in my physical therapy. And my therapist kept advancing my training, and I began weightlifting, and within 12 months went by, and I was now walking without a cane. I started biking. In fact, I was able to do a 20-mile bike ride. So that radically changed how I thought about disease.
That's really incredible. And you were pretty active before this all happened, so it was a big diversion when you went down.
Yeah, before I went to medical school, I was an athlete. I had competed in full contact taekwondo. As a matter of fact, in 1978, I was a bronze medalist in the Pan American trials for taekwondo.
That's awesome.
Yeah, so I was a real, sort of a kick-ass girl, so to speak.
No doubt. Quite literally.
Yes.
So yeah, big change. And it was soon after the symptoms were shifting, that's when the rheumatologist encouraged you to start sharing this. And
yeah, he said that this was so stunning that progressive multiple sclerosis recovered to the level that I recovered. So he gave me the job of getting the case report written up, and then called me back and said, I want you to do a safety and feasibility study, and helped identify some mentors to work with me. So he was immensely supportive. And, and by the time he had finished during that transition, he had gone from being the chair of medicine to the dean of the College of Medicine. And so, if the dean calls you in and says, "This is what I want you to do," of course you say yes. I'm happy to do that.
Right. That's really neat. So the first study started some time back. You've got another one you're working on right now, correct? Where you're comparing a couple
Yeah.
of diets.
So we have, I've done 3 studies. The first one was a single arm, just to see if could people implement everything they could. We had great results. The next 2 were randomized, weightless controls. Again, they showed people could implement the program and that it had remarkable improvement on quality of life and motor
So
function.
the weightless controls, just to expand that really quickly. So that would mean that there was people that wished to participate, but just randomly did not, and they were monitored. Well, those that were on the diet were on the diet and compare. Is
Correct,
that correct?
correct.
So you had a
And
good comparison group to look against.
exactly. And it's very helpful to have a randomized group so that that reduces bias and is considered much more powerful evidence of how effective the intervention is. And so that and that those early positive studies then let us get funding for a much larger study funded by the National Multiple Sclerosis Society with over $1 million really. So in this one, we observe people for 12 weeks eating their usual diet. Then we randomize them and train them in the study diet. And here we're comparing a low-fat diet, the SWANK diet, to the modified paleo diet, which is the Wahls diet. And again, we measure quality of life, walking, thinking, vision. We do the ocular coherence tomography, a little more detailed visual assessment. And then we collect a bunch of blood biomarkers as well. And we have a bunch of blood in the freezer in addition.
So I'd love to hear your thoughts on this. I'm, as an outsider to your specialty, I'm just loosely aware of the swank diet, its history. Tell me if I'm wrong somewhere along the way, but basically he did a quite low-fat diet with some foods with omega-3 fats and otherwise mostly unprocessed foods. And there was some benefit seen. I don't know the level of rigor or how significant it was, but that's just,
Sure.
and this was what, 50s, 60s or so? Or
So he started
Roy Swank?
1955, Roy Swank, and he had made this observation that during World War II, people on a lower fat diet, because of the rationing that occurred during World War II, had lower rates of MS and slower disease progression. And at that time, cholesterol and fat were thought to be the driver of heart disease, and he thought that MS was related to vascular health. So in his clinics, he trained everyone on a very low-fat diet, originally 20 grams of fat. He let them have sugar and white flour to make the diet more palatable. And then over time, he screwed it down further to 15 grams.
Wow.
And he had about 150 people that he followed to 50 years or death. And so this is really a long case series.
Yeah.
There's no control. And the other, so there are several criticisms. There's no MRIs. There are no blinded assessors. However, we do have this long duration of the study. And one of the potential problems are that people drop out and they are lost, probably because they didn't respond really well.
Sure.
And he lost about half of his folks. On the other hand, he did observe that people, if they followed the diet, they were less likely to have their disease progress. If they did not implement the diet, they were more likely to have their disease progress. And so, and he wrote his book for the public after having written, a 3-year report, 5-year report, 7-year, 20-year, 36-year report.
Wow.
And then wrote a book for the public. Then he really got a lot of negative feedback by the neurology community. And there is one randomized prospective study that looked at a vegan version of a low-fat diet, the McDougall diet. And they had, I think, 61 people in their study, a weightless control. And they found that Total cholesterol went down, weight went down, but there was no difference in MRI lesions or in relapses between these two groups. And so, I mean, we're looking forward to seeing, and because we have a observation period, we'll be able to see if either diet reduces disease activity, improves quality of life during the relative to the observation period, and then is one diet better than the other?
That's fascinating. I think there's so many questions, and interesting to see how the data comes out. But I wonder if there was any common elements amongst both diets, or if the swank diet just didn't really get a chance to be observed very well. If maybe it just didn't have an effect, or
So we don't have any randomized controlled trials of the swank diet. We have that McDougall diet that had some favorable changes on lipids, but did not have statistically significant changes on quality of life or fatigue. But maybe with a larger group, they might. We'll see. It'll be very interesting. Whatever we find will be incredibly important. Yeah. I expect that both diets will have some improvement relative to the observation period. Of course, I'm optimistic that the modified paleo diet will have a greater level of improvement than the swank diet. And part of that is we have much more appreciation that the microbiome is really important, that the added sugar is a huge problem. And so we'll see. Yeah, and I think gluten and dairy are a problem for many. I don't know how many folks with MS have that, but we expect that is a contributing factor for many folks as well.
Just, I guess, one last curiosity about that. So the swank diet, the version that's being studied now, is that just with the instruction of a certain number of grams of fat, or is it more so a whole foods diet as well? Or?
Well, so swank, his original diet was really focused on the fat. We went with what's being used now on the Swank Foundation page, which, by the way, has been heavily influenced by my work, because now they're talking about these radical things known as vegetables and encouraging people to have more vegetables. So okay, so we aren't using Swank's original definition in the guidebook we give our patients. We encourage them to have the fat restriction. We encourage whole grains and encourage vegetables. But the definition of did they follow the Swank diet or not will be based solely on did they stay under 15 grams of saturated fat.
Got it. So compliance with other factors won't be relevant in terms of determining their level of compliance.
Correct.
Well, that all sounds very fair and generous, to really take the better, newer readings of that as opposed to it would almost seem, I don't know, unjust to put someone on the old recommendations if they had no talk about food quality.
Well, and we wanted to use what is readily available to the public now. So we do give people a copy of my book or the copy of Swank book as part of the protocol. And then we used the dietary recommendations from the Swank Foundation website.
One thing I love about your work is everyone says eat more vegetables, but you say how much more. There's such a difference when you quantify something or when you leave it vague. I think there's just so much power and magic in numbers. And I love that you say, no, 4 to 6 cups or, a specific amount here per this phase. This is how much you want to consume. And here's the categories of vegetables you want to get within that.
Yeah, we give them a very precise recommendation now. It's 9 cups of vegetables, 3 cups of greens, 3 cups of sulfur, 3 cups of color. And if you're still hungry, eat more vegetables. If you're over full, we're not asking you to overconsume. So we don't ask people to overconsume, but we want to make it very clear. We don't want you to be hungry. Mm-hmm. If you're hungry, keep eating the allowed foods. But we also, it's different from the paleo diet. The paleo diet is meat heavy and you have some vegetables. We have some meat and a lot of vegetables. So it's really a little more, you might think of a merge between a Mediterranean diet and the paleo diet, sort of the best aspects of both.
That's wonderful. We'll be right back after word from Integrative Health.
We hope you're enjoying this episode of Medical Myths, Legends, and Fairy Tales. This is Dr. Raquel Espinal at Integrative Healthcare. You know, so often we hear from our new patients that their primary care physician has told them that their thyroid and hormone levels are fine and they should not worry. Yet the patients still have symptoms of severe fatigue, thinning hair, and weight issues. Unfortunately, this is too common with thyroid care. The good news is we can help and there is hope. The doctors at Integrative Health, including myself, specialize in naturally treating your thyroid, your hormone, and adrenal issues. We would love to get you started on the path to ideal health. From the comfort of your own home, you can get treatment with one of the doctors at Integrative Health via telemedicine. Go to integrativehealthcare.com to become a new patient today. Use the code PODCAST20 for 20% off your new patient visit. Again, that is integrativehealthcare.com and use the code PODCAST20, all one word. Get back to the road to thriving. We look forward to seeing you.
And now, back for more medical myths, legends, and fairy tales. So this stuff, a lot of these things you started some time back, and the TED Talk was a big part of it becoming really public, but what's gone on now in the last several years? What are some updates that have happened with you?
You know, so when my book came out in 2014, our research from our pilot studies we're in the process of getting published. So those are now published. And we've had like 6 papers come out with various aspects of our work. And the neurology MS research community now talks about my research. They include us in meta-analyses when they're looking at dietary studies or looking at fatigue treatment strategies or looking at progressive MS. So that's exciting to see. There are more studies, a handful of studies with ketogenic diets in MS. And those studies have shown that ketogenic diets, in fact, are helpful, or at least in those small studies that they were. And when we look at clinicaltrials.gov, there have now been 13 dietary, like food-based studies, not supplements, food-based studies that have either been conducted or in the process of enrolling or will be enrolling in the future for MS.
Wow.
And what's remarkable is 4 of those studies, I'm the principal investigator, and we have another study that we'll be recruiting for probably later this fall, and so that'll be 5 out of the 13 have my name on it. So I'm the person with the most experience doing dietary intervention studies in the setting of MS.
So 5 out of the 13. So the others have come out in the recent past. Is this part of a general momentum
Correct.
that's been started
Correct.
now? Or?
Yeah, you know, when my book came out, that really stimulated a huge demand and interest in the MS community for dietary and lifestyle research. And you have to give credit to the National MS Society. They recognized that was happening. They had a wellness conference in the fall of 2014. And then as a result of that, made doing dietary research a priority. They also made a priority of getting educational materials for patients and clinicians, which that was the first thing they did. And that included a discussion of the studies about diet, and including our early pilot studies, and a discussion about the modified paleo diet. So that was positive. And then when they made doing dietary research a priority, the MS Society began putting some funding, early funding, in dietary research, which is how and why, really, there are these 13 studies. Without the MS early support, that would not have happened.
Are you aware of any similar things that have occurred in other specialties, other disciplines of medicine in the recent past? Or
well, yeah, I think it's probably a spillover effect. There are some dietary studies now in Parkinson's. and in Alzheimer's cognitive decline. Not as many, just a couple of studies. So the MS diagnostic group is further ahead, but it is exciting because for the longest time, my colleagues here, I think correctly so, would tell me like, look, Terry, the NIH is only going to fund a study that looks at a single molecular pathway because they want to know the mechanisms of why things are happening.
Yeah.
And now finally we're recognizing that life is incredibly interconnected, complicated. And if you want to address these complex diseases, health behaviors are going to be hugely important to study. And so now, in just the last couple of years, we have studies looking at health behaviors, health coaches, exercise, and diet, and sometimes all of that in one study.
So part of this is also a shift in funding. In the past, so much funding had been looking at a single mechanism because the goal was to have a patentable product come at the very end of it, a drug-based therapy. And that had been a stumbling block about lifestyle therapy. So we're now seeing other funding avenues open up, apparently.
Yeah, the NIH is finally willing to do some of this funding. And I think another thing that is probably happening, because how I get funding to do my many pilot studies are with my work out there. People with money and a complex chronic disease discover my work, have a health experience that's transformative, and then a few of them call up the University of Iowa and say, I see that Dr. Wahls has a research fund here, and I'd like to make a donation. And so the university's had a surprising number of individuals call to make surprisingly large donations, which is how we're able to do those first several rounds of small pilot studies, and how we're doing some basic science work now with my frozen biomarkers.
Your frozen biomarkers. Tell us a bit more about that.
So as we've gone along, we've collected blood, urine, and stool from my various studies. And so some of my basic scientists here at the university have learned that I have these biospecimens. They've come up to me and have some conversations about ideas that they would like to have funded. And we've been able to develop partnership with some of my prospective donors to get investigations of these biomarkers. We've gotten some MRI studies going. We've gotten a study going right now looking at the stool and the change in the microbiome. And we're looking at wanting to investigate carotenoids and metabolomes and oxidative stress markers. So
trying to find various markers that are predicting the clinical progress? Or?
Yes. What we're theorizing is we've already known the clinical course in these various studies. And then we're theorizing, are some of these biomarkers, how will they change? And what will be the relationship and the change with the biomarker to the change in clinical course? So now what's happening, Alan, is I'm getting down to what is the basic science? What are the mechanisms by which my diet and lifestyle is having such a profound impact?
And benefits to that are obviously many. One can see who may be, if they're not responding, you could check and see perhaps they're not compliant in some way. You could see that by the markers. You could get a sense about someone's odds of recovery. Perhaps if they already had that marker in place going into it, they may not be as strong of a responder. So lots of things that could open up.
Because we have poop, and now there are some biomarkers that you can measure in your urine and stool that will tell us, is gluten being excreted in the urine or stool? So I'll know, were you as compliant as you thought or as you reported? And so that may explain some of the levels of success that people experienced or did not experience.
Sure.
And frankly, that'll be another really interesting area of investigation after my current study is done, is to go back and look at some of the biomarkers that we can use to measure, did they eat all those vegetables we wanted, and did they avoid the gluten and dairy as thoroughly as we asked them to?
Well, that'll be fascinating to compare the responders against the non-responders. It might be the case that exactly as it was prescribed, that's how it worked best, and some just didn't follow it well. It might turn out that some facets were better predictors of the outcome than others, and perhaps it could even be refined.
Yes. And having biomarkers that can correlate with dietary adherence will be very helpful.
Yeah, that's incredible. And just to call this out again, the big distinction, a lot of people have had ideas about disease conditions or strong personal experiences or strong clinical experiences. And perhaps they've even shared that in some ways, but none have really had this ripple effect that you've had, and it's been because you've put this into good data. So it's been my bias that many in the conventional world who do rely on drug therapies really don't do so out of a conviction as much as a lack of evidence for other approaches. I've heard many that if there was good data for diet or lifestyle or whatnot, they'd be happy to go with that. But they've often just not had the data for that, and that's what I've seen different about your work. Would you agree that that's the perspective of many in the conventional world, or?
Well, absolutely. I think for many folks, particularly now, if you're in a large medical system or you have a large insurance practice, you're held to the standard of care. And we'll take MS. So the standard of care is that you're going to use disease-modifying drug treatment. And there really is no standard of care, embarrassingly enough, that says, and you're going to refer them to a nutritionist for diet and a physical therapist for an exercise program, and someone to train them on a mindfulness practice. Although there's great science that those things would matter, that they've not become a standard of care within a large medical organizations or the health insurance companies.
Got it. So that's the next level.
So, but if we want to change those standards of care, which I'm committed to doing, then that obligates me to do the randomized controlled trials so we can build the evidence to warrant changing the standard of care. You have to have a really long horizon in terms of goals when you want to do things like this.
And overall, the response you had within your community has been receptive towards this. Is that correct?
Well, that's been a journey.
Okay.
So in 2008, when I first started talking about this to the local organic grocer and the local community college, the local MS chapter wanted me to come speak. And I said, fine. And then I had to get interviewed by their clinical advisory board, and they were deeply alarmed that the public might refuse to utilize disease-modifying therapy and that I was creating false hope.
Oh, wow.
So I got banned.
Banned from...
But, I get banned as a MS Society speaker.
Oh, wow.
Because I was creating false hope. But, and then I had to go meet with my chair of medicine and the chief of staff at the VA to explain why I was a banned speaker. And they had me go meet with the head of the complementary alternative medicine clinic. And actually, that was probably really very helpful, who then made sure that I was following FDA guidelines and speaking about this much more carefully and precisely, that I was not advocating that people stop their drugs, but I was advocating for them to talk with their physicians about diet quality and stress reduction and exercise. So I was, very precise about how I would talk about this in the public, precise about how I would recommend this in the medical records. And in the meantime, I'm doing my clinical research. And my research is getting remarkably positive. The College of Medicine has an annual research week, and the Department of Medicine has an annual research week. So I'd present my research every year, and you'd see just how successful we were. And then we started showing our gait videos where people, their walking and motor function improve so remarkably. And then our papers start coming out. Then, I published my book and my TED Talk. And then the MS Society, now I have all these papers coming out in peer-reviewed journals. And now my research is being cited by other scientists. And then the MS Society funds me with a major grant. It was one of their largest grants they've given to date. And so now, in fact, instead of being seen as this odd, eccentric, we don't quite know what to do with her, the university is like, man, this is really brilliant. And they like the fact that I have a social media presence and I go around the world talking about my work and what I'm doing and why. And they recognize that this increased visibility has led to increased philanthropic support. Actually, they've said, they've thought about having me talk to some of the other scientists about what I'm doing and why to help my colleagues have a bigger public presence to increase the philanthropic support for their labs as well.
That's got to feel nice to have it come around like that and go in full circle almost. And
it's remarkably fast. If I think back to 2009, where there's a fair amount of resistance and people didn't quite know what to make of me, to just 10 years, I now have a secondary appointment in the Department of Neurology. I've met, and I periodically meet with the neuroimmunology the MS clinic at the university to discuss interesting cases with them. And I am funded by the MS Society, and the concepts I've been talking about, now you see these review papers in the literature saying, yes, diet and lifestyle should be a critical part of every treatment plan to preserve brain function. So it's a remarkably short time period.
I love your perspective on that. I could see someone who's, I don't know, at the early end of a state of facing contradiction or whatnot, seeing that, thinking that it would never change. But yeah, 10 years, to look back on it, I could see it being brief, but moving forward, you could have gotten bogged down along the way and you didn't.
Well, there's plenty of challenge, but there's also a very clear purpose. In 2007, it was so clear to me that I was destined to be bedridden, quite probably demented, quite possibly intractable, untreatable pain. I got my life back. I felt this moral obligation to teach the public and to do my little clinical trials one at a time to show, could this help other people? And so I just had a very clear purpose. And fortunately for me, my chief of medicine, then dean of medicine, got me connected with some really great mentors who guided me forward step by step. Just like, you write your grants, you do the little science that you have funding for, you just keep plugging away.
That's so cool. So as we're speaking, the Wahls protocol, your main book, was a big part of making this public. So we've got a version coming out. This is coming out now. This is an updated version happening. And
yeah. So, so much has happened since the original book came out. We've had, all these clinical trials, and there's so many more information about fasting, ketogenic diets, a lot more information about rehab and the use of electrical stimulation. So I revised the book, and it's about a third new material.
Oh, wow.
With all of this new information. Plus, since the book was still so popular, doing so well, I had to fix all the things that were no longer quite correct. So I wanted to be sure that everyone had great information to guide them.
Things that changed along the way, or things you would have just said differently, or what do you mean?
Well, some things that changed, ketosis. I used a lot of coconut milk and MCT oil to help people get into ketosis, which is the easiest way to get into ketosis. But I did not caution them enough that they have to follow their lipids really closely to be sure they don't become have their cholesterols become too high and the triglycerides become high.
Sure.
And that there are many other ways to get the benefits of ketosis other than relying on coconut milk and MCT oil. So there's a much, much richer conversation about why ketosis is good and the many different ways that we can pursue it. That coconut milk is delicious, and that might work for you, but you have to follow your lipids closely. But there are other things you can do with time-restricted feeding, intermittent fasting, periodic fasting, just very low glycemic index eating. So huge expansion there. And I'd say a much more robust conversation about rehabilitation.
Mm-hmm.
Some people would look at my remarkable progress to go from being unable to sit up to biking 20 miles 1 year later. And so I have, I think, a much more detailed conversation about how I was able to achieve that. And a little more guidance for people who may have comparable levels of disability, what strategies they could use to improve their chance of successful rehab.
Is the issue about people just not being prescribed rehab, not pursuing enough, or is it the type they're doing or the duration that's not ideal? Or
Well, a lot of people with MS are not being prescribed rehab. They're not being sent to physical therapy or occupational therapy. And even if they're being sent, their physical therapist, occupational therapist don't consider that rehabilitation in a severely disabled MS person is possible. Their goal is, I'll just try and slow down your decline. And so we talk about that. I also talk about the role of some of the additional devices that are available to help with rehab, such as electrical stimulation of muscles, functional electrical stimulation of muscles, how to access that, and how that could be part of your rehab program.
or you're just saying how the therapist themselves having no expectation for benefit, I could see how that could have a huge effect upon the outcome.
Absolutely. And they don't understand that rehab of function is really possible. They don't help people set goals, and they don't tell them about all the tools that could be used. So a much more, again, robust conversation about the issues around rehabilitation.
That's great. So in synopsis, our listeners who might be struggling with MS, neurodegenerative diseases, what are 3 things you would suggest for action steps for them to do right now?
The first thing that I think is critical for everyone is to have a very clear purpose. I call that personal mission, so that you know why you're willing to do all this work. So it might be having a clear understanding of what you want your health for. In my case, as I was getting more and more disabled, I had 2 really young children, and I knew my real goal was that I wanted my kids to be emotionally and financially successful adults. And if I gave up, I was teaching them that because they're, kids, they don't listen to us, but they sure watch what we do. And so I just gave up. They would be internalizing that you just give up when things are hard. But if I stayed with it every single day, always working out, however limited it was, and always going to my work, they would get the message that, yep, life's not fair, but you do the best you can every day anyway. So having that mission and understanding what you want your health for, very helpful. Then the next 2 things that I'd have people work on is improving the quality of the diet. One, by removing the foods that are potentially making you much more inflamed. and that's gluten, dairy, and eggs. Because that depending on your genetics, may cause a abnormal immune response and increase the inflammation in your brain and the damage to your brain. And then the other thing to do is to ramp up these radical things known as vegetables, the greens, the sulfur, and color. And what I explain to individuals is that if you want to do the test to see could diet and lifestyle help you, you have to do the test 120%. If you just want to tweak your diet a little bit to try and reduce your risk of cancer or stroke or heart attack, just adding more vegetables and sort of doing the diet about 80 or 90%, that might reduce your risk of cancer, but it won't answer your question. Could diet turn off your disease activity? If you want to answer that question, you have to really be willing to do the diet 120%. And I tell people, pick out 100 days, pick out a start date and an end date, and then be all in for that 100 days.
That's great. I think often people think that if they give at least partial benefit, they could at least see some partial improvement. But often lifestyle, that's not the case. And so you're telling them straight out, if you want to see if it works, you've got to do this full on.
Yeah, it helps them a lot to acknowledge that if you were in a college class or in high school class and you got an 80%, that would be like a B. And so you'd think that would be good. Or if you did 90%, that'd be like maybe a high B plus or an A. But for this question, could diet turn off your disease activity? Then you really have to be at it 120%.
Well, and I always think about there's some forces of degeneration and some force of regeneration going on constantly. There's always things that are breaking us down, be that just the aging process, the various stressors of life, or an active disease process. And then our body has its own homeostatic mechanisms. And yeah, it might take a fair amount to really turn that tide. And you could do some things that are helpful, but if it's not enough to completely shift that balance to where your regeneration has overcome the degeneration, there'd be nothing visible.
You have to be all in. I mean, if you really want to know, you have to be all in. But planning when you're ready to do this will help.
That's awesome. So are there closing words of thoughts or inspiration or points that you want to address that we didn't get to? Or
I am immensely grateful for this whole journey. I had to become profoundly disabled to be willing to do all the work I put into reading all the basic science and the functional medicine, the ancestral health principles to, in the end, be able to integrate them and create this protocol. And by having been that disabled, and now having this amazing recovery where I can bike and be active, it's given me this remarkable personal story that I can share with the public. And it also gave me the drive and the sense of moral obligation to, one, tell the public, and two, do the clinical research so that we could change the standard of care.
That's awesome. Dr. Terry Wahls, thank you so much. I'm going to tell people about the new updated version of the book and put links out about your work on these show notes. They can have many directions to go to. And yeah, I appreciate your time. Always glad to hang out.
Thank you so much.
All right. And thanks for tuning in with us. I'll be back with you real soon for another episode of Medical Myths, Legends, and Fairy Tales. Bye-bye. Hey, Dr. Christensen here. Thanks so much for joining me for another episode. Is there a topic you'd like me to cover? I'd love to hear from you. Just go to Dr. Alan Christensen on Facebook or Instagram, write your question, and use the hashtag #MedicalMyths. Did you find this show helpful? If so, please take a minute and leave us a rating on iTunes so that others can know. Thanks much, and I'll be back with you real soon. Bye-bye.